네, 아주 짧지만 강렬한 메시지였는데요.
Although short, the message was very strong.
핑거라는 단어 아시죠?
You
이거는
all
영어로
know
하면
the word,
손가락이라는
the English
뜻인데요.
word finger,
스웨덴과
which represents a
핀란드에서는
part of our
2012년부터
body. But
운영하고
in
있는
Sweden and Finland,
치매
since
예방 프로그램의
2012, a
이름이 또
dementia preventive
핑거이기도 합니다.
program called
핑거
Finger
프로그램의
has been
의미는요.
operated.
약물을
Finger
복용하지
programs
않고 치매
aims to
발병을
prevent
예방하는
dementia
건데요.
without taking a medicine.
수년간의
Several
임상적인
year-long
실험 그리고
clinical
추적
trials
관찰을 거친
and follow-ups
과학적인
have been
프로그램이라고
made
합니다. 오늘은
to
핑거
establish the
프로그램을 개발한
scientific
스웨덴
program.
카톨린스카
So we have
대학의
Professor
미야
Miia
키비펠토 교수님을
Kivipelto
모시고 그리고
at
핑거
Karolinska
프로그램이
University in
어떻게
Sweden,
치매와
the creator of the
알츠하이머를
finger program, as a
정밀
speaker.
예방에 도움을
She's going to
주는지 이
talk about how
프로그램이
this
어떻게
program
그런 일을
helps
할 수 있는지
prevent
들어보도록
Alzheimer's
하겠습니다.
disease.
지금 스웨덴은 아주
It
이른
is
시간입니다.
very
그럼에도
early
불구하고 이번 포럼을 위해서 라이브로
morning
연결해
and
주신
early morning in Sweden.
카롤린스카
Despite
대학의
such
미야
an early hour for this
키비펠토
forum, she has prepared
연사님을
her
모시도록
presentation.
하겠습니다.
Please welcome her.
Professor Kivipelto, what time is it over there in Sweden?
It's very early morning. It's 5 a.m. Good morning, all.
Good morning. Thank you so much for joining us so early in the morning, joining us live like this. We're so curious about this finger program of yours. Are you ready?
I'm ready. Thank you so much. Here are my slides. I hope you can see them now. So, good morning, everyone. It's a great pleasure to be here today and talk about the prevention. What can we do to prevent dementia and Alzheimer's disease? And I will give a short presentation about the finger trial and the exciting journey we have started when we are moving from finger to worldwide fingers. And to start with, I think we can say that it's getting clear that dementia and late onset Alzheimer's disease are very complex, heterogeneous and multifactorial conditions. There are several disease mechanisms. It's not only beta amyloid and tau, there is inflammation, there is synaptic dysfunction, there is vascular dysfunction as well. And actually, it has been estimated that only 10 to 30% of AD cases have the pure Alzheimer pathology. All the other cases have more mixed dementia. And we also know from observational epidemiological studies that there are several risk and protective factors throughout the whole life course, and there are interactions between genetic factors. So taken together, we can say that there is a clear prevention potential. There are several targets and time windows for the interventions and for the prevention. Exactly how much we can prevent dementia and Alzheimer's disease is the next question. We do not know yet. There have been different estimates, and the most recent one is from the Lancet Commission paper, estimating that about 40% of dementia is related to these 12 modifiable risk factors listed here. As you can see, we have these traditional vascular metabolic risk factors like diabetes, high blood pressure and obesity at midlife, physical inactivity, depression, smoking and low education. And then there are also some more novel new risk factors like hearing loss, traumatic brain injury, high alcohol consumption, social isolation, and air pollution. If we turn this discussion from risk factors to protective factors, can we do something to reduce the risk? Here we have, of course, the healthy, balanced diet, and in general, we can say active lifestyle. We have been also studying some new, even more novel risk factors, not only depression, but also feelings of loneliness and hopelessness. These factors have been getting more and more interest, especially during the COVID-19 pandemic, when we have more the physical distance. Factors like stress and sleep disturbances have been getting more interest. At least at our memory clinic, I see more patients, even younger patients, who have challenges with stress and sleep problems. activities. So we can say activity is good, but brain needs also rest and some sleep. Impaired oral health can be related to dementia through inflammation, infections, and also poor diet. And of course, then infections. There is intensive research going on, for example, to understand what are the effects of the COVID-19 infection on the brain health. Can it even increase the risk of cognitive impairment and dementia? I'm very happy that risk reduction and prevention have been getting a lot of interest by several stakeholders. It has been really seen as the main key element if we want to manage the dementia epidemic globally. And I have been participating in the WHO risk reduction guidelines published last year. You can find guidelines using this webpage, which I have mentioned here. And I think this is really an important document, giving to us the evidence base for different countries, how we can implement this risk reduction work. These WHO guidelines are also giving to us signals, where do we have the gaps in the research? And it's clear that now it's important to try to move from the knowledge, which often comes from epidemiological studies, to clinical trials, and try to develop sustainable implementation. And here I would like to highlight two key components and concepts. One is the multi-domain interventions. Giving this complexity, the multifactorial etiology of dementia, I believe that we need to target several risk factors and mechanisms simultaneously to get an optimal preventive effect. I call this multi-domain intervention. The second important concept is brain plasticity, meaning that everything we are doing is affecting the brain structure and function. And this brain plasticity is still there when we are getting older, so there is a possibility for lifestyle interventions. At the same time, we know now that one size does not fit all. In the future, we need to tailor the interventions to specific risk groups, specific populations, and specific individuals. We all have different risk profiles. And we also need to learn more about the mechanistic foundation so we can tailor the interventions even better. I'm leading the FINGER trial. And this was the first trial in the whole world showing that it is possible to prevent cognitive impairment among at-risk elderly persons from the general population. And in the FINGER trial, we really used this multi-domain intervention. It's like one hand and five fingers with nutrition, exercise, cognitive training, management of all vascular risk factors, and the social interaction as well. This package was compared with the control group, the regular health advice. And as you can see here, we had totally 1,260 elderly persons between 60 to 77 years who had increased risk for dementia based on different risk factors. Intervention was 2 years. Now we are ready with the 5 and 7 year follow-ups, and I hope to start the 10-year follow-up next year if the COVID-19 pandemic is getting the possibility to that. And I really think the extended follow-ups are important to learn more about the long-term effects of this kind of intervention. Here you can see the main results of the multi-domain finger intervention. Global cognition was getting much better in the intervention group, 25% more improvement. And also all the cognitive subdomains, executive function, how we are planning different things, if we can do some multitasking, 83% more improvement. Processing speed, 150% more improvement, and even memory, 40% more improvement. So this is not only to prevent dementia, these activities, these cognitive domains are really important for daily living for all of us. And on top of that, we could see that both cognitive decline and functional decline was less. There was less risk for functional decline. There was a better health-related quality of life, and importantly, 60% lower risk of other chronic diseases, multimorbidity, and linked to that, 20% lower risk of hospitalization. So it's not only brain, it's also beneficial for the whole body, and there are even cost savings related to this. As you may know, ApoE4 is the main genetic risk factor for dementia. And we were very happy to see that ApoE4 carriers got clear, very clear beneficial effect of this intervention. And our very recent findings still impress. We could see that this multi-domain intervention would counteract shortening of the telomeres, again among the ApoE4 carriers. And telomere length is kind of a measure for the cellular aging. So this means that this type of intervention is also having effects on the cellular level, which is very important. And what we are doing now, we are really trying to understand what are the mechanisms of this intervention. Can we see some changes in the brain? Can we visualize changes in beta amyloid, glucose metabolism, markers for inflammation? This is ongoing study, and I hope that this can help us to understand more about the novel molecular signatures and mechanisms, and as I mentioned, help us to tailor the interventions even better in the future. Finally, a few words about the worldwide fingers. Finger has been getting a lot of interest globally, which is really fantastic. And now there are many countries, including Korea, which want to test, adapt, and optimize the finger model in different settings and in different populations. And to really support this movement, we established Worldwide Fingers 2017. I'm the scientific leader of Worldwide Fingers. And here one goal is really to try to have a prospective harmonization of research methods and share experiences, work together. And I think this harmonization is really, really important because that can help us then to compare the results when they are there. And I'm happy to tell you that today, 2020, 3 years after we launched Worldwide Fingers, there are 30 countries from all continents participating in the Worldwide Fingers. Here you can see with dark blue the countries having ongoing trials, and with lighter blue countries who are in the planning phase. If you want to read more about this, I have been writing here the more recent publication describing the network activities. Of course, COVID-19 has been affecting the interventions, but we have been having a lot of meetings trying to solve this situation, trying to find creative ways how we can move on with the interventions, how can we analyze the data despite the pandemic. And again, this has been wonderful teamwork. And as I said, really the key components here is big data, harmonization, sharing, and local adaptations. That is really the key, because if we want to have sustainable interventions, they need to be adapted to the society. And again, this is a wonderful opportunity to collect novel biomarkers, both from the blood, and we have been even planning biomarkers like microbiome. Just one example from the Worldwide Fingers trials called MIND-AD. What is innovative here is that we are targeting patients who have early Alzheimer's disease based on the prodromal AD biomarker criteria. This is an important patient group because, as you know, we do not have yet any disease-modifying drugs. So it's important to really see how much we can do with lifestyle interventions. And another innovative feature in the MindAD is that we are combining finger intervention with medical food. I really think this is the model for the next generation of clinical trials. It's not lifestyle or drugs, it's the combination. And in MindAD, we combine finger with the medical food, Fortasyn Connect, that is omega-3 based and having lot of important nutrients for the brain health. And this is based on our previous studies from lipid diet, where we could show both after 2 years and especially after 3 years that this medical food is having positive effects on cognition, function, and against brain atrophy. So very interesting findings. Again, you can read more from the articles I have listed here. And one more novel trial design which I want to mention. We are updating the finger to Finger 2.0, even more advanced, even more personalized lifestyle model combined with possible disease-modifying drug. In this trial, which we are starting next year, we are using metformin. It's the diabetes medication which have been linked to dementia and Alzheimer's disease. Very exciting trial design, and as you can see, this is a multinational study which I'm leading, and again, showing the way to the next generation of clinical trials where we are combining lifestyle and drugs. And the final note I have is the possibility of using new technology to really facilitate personalized, effective, and feasible interventions and implementation. I would say that the need is especially clear now during the COVID-19 pandemic, when we can't have as much face-to-face in real life visits and interventions. So we need to find ways to use the new technology to support in the self-management and support in the measures. So I'm talking about the concept e-fingers more and more. And we can also use different ways to analyze the big data we are getting. We are having already now wonderful examples like apps, computer-based training, robots, machine learning, artificial intelligence, and clinical decision support. This is really an exciting area for the future. And one final thing I want to mention is our COVID-19 Worldwide Finger Survey, which is also going on in many worldwide finger trials. This is really aiming to map how the pandemic has been affecting elderly persons. Even the indirect effects of the lockdown, more isolation, maybe less physical activity, less optimal management of chronic diseases and risk factors. And we really think this is important because we need to try to minimize the risk for the longer term negative effects, that is also negative risk factors for the brain health. So I'm very happy that many countries are included and involved in this joint effort where WHO is also involved. So my take-home action points. Dementia is a multifactorial complex disorder, and I believe that the multi-domain interventions is the way to go, and we have evidence from finger that they are effective and feasible. At the same time, one size does not fit all. We need to move from the complexity to precision prevention and tailor the interventions for specific at-risk profiles. In the future, combination non-pharma and pharma, and using more new technology. And global collaboration between different stakeholders is really the key. And here, sharing experiences and data, harmonization, long follow-ups, and implementation. We are having already enough evidence for many of those risk factors I mentioned that we can move on to the pragmatic prevention programs. At the end, I want to thank all my colleagues who have been participating in these trials and all worldwide fingers countries. And I really thank you for the active contributions, and I hope I can visit you in the close future. Please stay safe and healthy and have a wonderful day. Thank you so much.
Thank you, Professor Kivipelto. Thank you so much for joining us so early in the morning for you there in Sweden. That was a very thorough presentation of ways that you are looking into preventing and treating dementia. Thank you very much.